Good evening. Thank you for joining us for part 2 of When a Disaster Affects Your Practice. My name is Phoebe James and I'm a Professional Development Officer with the Hunter New England Central Coast PHN. I'd like to start this evening's event by handing over to John Bailey, who is our Executive Manager for Primary Care Improvement. Thanks, John.
Thanks, Phoebe, and welcome everyone. Can I welcome you to, as Phoebe said, the second in our series of 3 when disaster affects your practice or impacts your practice. Tonight we're really lucky to have Dr. Catherine Palmquist with us, who until recently has been a GP advisor to our disaster and emergency management team, and Scott McLennan, who is an officer with the New South Wales SES on the North Coast up in beautiful Grafton. And again, thanks for joining us and welcome to tonight's event.
Thank you, John. My name's Ellen Senft. I'm the Primary Health Network Manager for Disaster and Emergency Coordination. Welcome for the second night. This is really exciting. We have infectious diseases as a topic and flood and tsunami. So we will start the evening with Dr. Catherine Palmquist, who will talk about infectious diseases. Thank you.
Evening, everyone. It's nice that we start on time. It's a really modern phenomenon, isn't it? No more dragging your heels into a meeting. It's right on. Just a little welcome here. I'm on Darkinjung country here on the Central Coast. I'm a local GP. I had a lot to do with the local respiratory clinic and the LHD's responses for COVID. And I just want to thank the PHN for asking me to talk about infectious diseases tonight. It's probably the easiest talk in our series because we're all so familiar with it. At the same time, probably the most difficult one to try and offer something useful. Let me just see if my screen's coming up. There we are. Is everyone okay?
Yes, that looks good, Catherine.
The silence is good. Thank you. So just a reminder, our lovely series that we've put together, the first one was really a great talk. I've had to listen to it. So if you've missed it, you should be able to access the recordings. So cybersecurity and earthquakes. Tonight I'll be doing the infectious disease outbreak, and we have some great talks following mine. And lastly, just the thunderstorm, asthma, fire and bushfire. So infectious diseases, they've been around for an awful long time. They've caused immeasurable harm across the entirety of the earth, really. And this is probably the first proper pandemic that we've all been through for COVID. And gee, we've learnt a lot from it, but it does remind us of our vulnerability. And it's really important that we don't get too lackadaisical having been through one pandemic and really work hard to think about how we can put some frameworks around an infectious disease outbreak, from even just the small local outbreaks that affect our clinics and our communities to the much larger outbreaks that really are very deadly and can affect such a broad range of people. So tonight, I'd just like to offer some thoughts about how we kind of structure and plan around future events, and hopefully we take some learnings from COVID. This is a very wordy little screen here, so read away if you like to, but it's really just reminding us that there are so many different ways that we can be harmed from a communicable disease. And just a reminder, what we're talking about here really is an event that potentially is quite serious to a range of people. So when we talk about a communicable or an infectious disease, we're talking about something that would spread between people. And we know that respiratory viruses are still at the top of the list of potential harm in this scenario, especially things like influenza. So just a simple flu, but we do know that it spreads from it can spread from animals to humans, and particularly birds. And we're all living in such close proximity, especially in certain parts of the world, that it really is a viable threat to another virus outbreak. So something that transmits quite easily. And from COVID, a good example that you can have asymptomatic spread, which makes that transition pathway really quite deadly and scary. People that don't have symptoms, so the route of transmission, so whether we're looking at a sexually transmitted infection or whether we're looking at fecal crossing or blood, all the different ways. Concerns with how rapidly something can spread, looking at who could be at risk of these diseases. So is it mainly affecting children? Is it an older, vulnerable population? Is it pregnant women? So framing it around all of these important factors. And the public perception and knowledge. So I know everyone knows about flu, and prior to COVID, it was regularly in the news if a couple of people had died of flu, and that even probably, I know a couple of years before COVID, we had a flu outbreak, and it was daily on the news that 3 or 4 people had died of flu, and it really created quite a swarm of people wanting to vaccinate. And you compare that now to COVID, where we're still having quite a lot of waves coming through and very few people interested still in the vaccine, and probably a bit too relaxed around it. So public perception and communication is really important with all of these entities. So before I go into this, I'll just recall a recent case that we've had here locally. We had an outbreak from one of our local conference centres. There was an Aboriginal health conference here close by, and slowly we started to notice that patients were coming into the ED with gastro and isolated from one kind of building and one conference attendance. Locally, the ED was navigating how many patients were being affected, realised the kind of transmission pathway, and brought into place. So I also work for Hospital in the Home, so we had a team that went out and attended on the scene to try and help. But equally, that could have been a GP practice locally. We had bags of fluids. We had kind of rapid assessment on the ground with blood pressure and basic bloods that we could do. Rehydrated, gave antiemetics, and tried to kind of contain to stop people from travelling around and possibly infecting people in a wider stance. So when we're talking about risk assessments for your practice, it's important to think of infectious diseases really at that grassroots local level. So has the pharmacist noticed more people coming in with a respiratory illness or a gastro, and how does that get relayed to the local GP perhaps? Or how do we communicate with our local allied health staff so we're all kind of aware locally that something's changed, or just being more alert that we might be dealing with something a bit bigger than 1 or 2 people being unwell. Similar for daycares. So there's lots of ways we can look at creating or being mindful of disaster management plans. The RACGP has their standards, and if practices are going through accreditation or want to learn more, there are risk matrices that can be used to kind of plan around disaster, of which infectious diseases is one. Using a risk assessment matrix, John went over this in his talk recently. It's really useful to kind of look at all of the possibilities in your practice and what you can pop on a matrix and share with your team. It's really important to use as many members of your team as you can when you're starting to do plans. So right down to the admin staff, sorry, not down, but just incorporating everyone. So the nurses on the ground, in your pharmacy, whether you have people working at the front counter or at the back, just trying to bring everyone into the discussion so you all kind of feel like a team. The PHN has a great decision guide, which will be coming out soon. It's just in the last kind of elements. So using some templates, if you happen to come across this plan or this template, it's got lots of pages of really useful information to kind of prepare your own practice or your own workplace, and looking at things like how many computers you have, what are all your backup plans, what is your PPE capability, defines it really nicely, and it's quite a difficult concept to get your head around, really, to plan for a disaster. So using a template's really useful just to do it in a staged approach. So I've been through this local case, and just to reiterate, I think there's so many different elements of an infectious disease, and really anything that we talk about in these series. So we've got federal investments, as we saw with COVID, kind of looking over our shoulders at what we're doing. And there's legislation federally, there's statewide legislation, particularly with infectious diseases. And internationally, we're looking at our borders when we're talking about infectious diseases and cases spreading. So we've got federal, we've got state, we have, seeing we're talking about health, we've got New South Wales Health that are very heavily involved and have their own protocols. Your local hospitals should have really clear disaster plans as well, and of that, the subtype for infectious diseases. And your public health unit, they were really integral for us, dealing locally with what was the local spread, what's the wider picture, what was our local contamination risk here on the coast, similar for Hunter New England. And then just thinking about all the different subgroups to that. So the local Aboriginal services and how they're linked in, and making sure all of the important stakeholders in health in your community are involved. So if there was an outbreak that you're concerned about, or if you happen to find something, we obviously, a few of our diseases that we pick up on swabs or stool samples go straight through to pathology, who will then record, and if it's serious enough or flagging, then the PHN and the public health unit are usually made aware of these issues. And for instance, at the moment, there's an outbreak of group A strep, so it should be distributed to the practices that there's something to be concerned about locally, and then it heightens your awareness. You might be more inclined to do some screening and some swabs, and to be a little bit more aggressive in how you treat patients that would otherwise just be thinking a simple sore throat. So having a really good communication with your local PHN is really important. So there's lots of different really fabulous graphs about how to prepare, which is the crux of this talk, for an infectious disease, or how we kind of put a framework around infectious disease planning. So let me just bring this up. There's lots of, we could start at the end, really. We could start at feedback and looking at your own practices and your own workplaces. So we've had COVID come through, so it'd be interesting to see how many people attending have worked in a workplace now that are recognising that we're in somewhat of our recovery mode here, and having a look back and thinking, what did we do well through COVID? What could we have changed? What was really useful? Were people involved that needed to be involved? Were there people left out? Were there groups in our community that needed more support? And really the big thing that came out was social policy and psychology that was really necessary. And I think that would probably be one of the #1 factors really for any kind of disaster planning going forward. And I know our team at the PHN have been talking and stressing how important it is to have really good access to emotional support and psychological support, both for staff, clinicians and patients. It's really an unnerving time, and the outcomes still from COVID probably won't be known for a long period, but recognising early that we need pathways to address really the impact and the increase of mental health that was in our community through such a thing. And I think this will carry on for a long time. People will really be looking over their shoulders for the next wave of an infectious disease on our doorstep. And financial stress that has come with it as well. So even just things like that affect a community in terms of infectious disease, even something that may threaten the livelihood of locals. So for example, if you're working somewhere where working on the land's quite important and something's affecting local animals, and you have a host of farmers that are really losing money in their livelihoods and perhaps their farms, or a drought. So not an infectious disease per se, but just the impact on people psychologically going through something that's kind of unexpected and affecting a community. It needs to be kind of #1 or very high up on our list of how we plan to help people. Crisis management, really for every kind of disaster, but particularly with infectious diseases, working out our roles and responsibilities. So thinking about where you'd like to fit in the chain of how you'd like to help your community or your practice, or just in your actual workplace. Knowing what your local links are. COVID certainly helped strengthen a lot of the GP networks. We really worked really closely locally with our friendly GPs down the road, and Central Coast, and certainly lots of other jurisdictions set up little local groups of practices, and that was just invaluable for us. I know we had a lot of communication with our local pharmacists and making sure all of our allied health colleagues were safe as well. And just the local connection is very important. In terms of infectious diseases, we really need to have a plan as clinicians to assess and be recognising if there's a change to what we'd expect of levels of disease. If there's something, that instinct that this is looking a little bit unusual, say for instance monkeypox, this has kind of sprung up out of nowhere, and I know there's been tetanus in New South Wales in the last year, little things that are so rare, measles, that we still need to be educating ourselves on, recognising and just thinking of infectious diseases in our workplace. Swabbing, testing, pathology, trying to pick things up and spread that out to the broader scope of colleagues. In terms of workforce planning, COVID really, especially early on, as an example of infectious disease, showed us that there are staff who would like to retire and leave and run wild from being exposed to an infectious disease, and others who really were able to stand and come to work. We also had people that needed to work from home. So in some ways, if you can plan ahead, whether it's 3 monthly, 6 monthly, 12 monthly, looking at your template and thinking, how would I adjust if there was a surge of illness in my practice or an infectious disease that I need to protect maybe some of my older staff from, or pregnant staff, and just trying to find that balance in your workplace. Infection prevention and control. So obviously PPE, and just planning around some of the common infectious diseases that you might come across. So most of them are universally protected by PPE. Vomiting, diarrhea, a respiratory illness, those are the main kind of sources. Hopefully we never see Ebola on our shores, and we're all pretty good at protecting ourselves against bloodborne illness. It's always that fear that something new turns up that we're not expecting, and hopefully not in our lifetime. So establishing really clear clinical pathways. It's good if the workplace you're in has a team meeting every so often, and maybe just table 1 or 2 infectious diseases every so often, so it feels like it's routine and prepared, and you kind of have a sheet or a pathway that everyone's following. Really important coming through COVID was the recognition that primary healthcare was really difficult to do. So a whole host of people are probably living with lung cancer at the moment who haven't been screened effectively. So I know that New South Wales Health is starting to roll out a program to do some low-dose CTs and offer them at a lower threshold than in the past. So somehow we need to brainstorm, and there's no solutions to this, but just kind of think, how do we keep primary healthcare going in the midst of an infectious disease crisis that's really keeping people away from our practices? And how do we find that balance between really acute needs of our community and some of the secondary, the tertiary, the primary healthcare, and really good solid GP work that we do. And again, for pharmacy, how do people come in and get their routine medications when they're really fearful of coming into the workplace? I know that a lot of local pharmacists set up a really good program of patients driving past or having someone that was well to come in and pop medicines through. And emails and e-scripts are probably quite useful in those scenarios. And it's been really interesting to watch allied health colleagues, how they've maintained a business and set up practices that are helping patients with their primary mental health. For example, schizophrenia at the same time as an acute anxiety, or how it's all kind of balanced. Links to pathology, so making sure that you have the right screening tools, you have enough equipment to screen or test as you need to, and that you're getting effective communication back from your local pathology, and having lots of equipment. We are all quite good at having access to urine bottles and swabs now, and stool samples and the like, but would we have enough if there was really large outbreak? The template that the PHN provides talks about finances and having some plans around where you're keeping your equipment. Recovery. So when you're planning for an infectious disease, we also need to plan for recovery. We've talked obviously about psychological health, but how we go back to business as normal, which is what we're doing now, opening up our practices, opening up all of our contacts with patients, but where we start considering it's normal business activity. And I know in our practice, we're still talking about masks versus not. So on a local level, kind of how you make decisions in your practice and in your workplace, and how that kind of blends in with your local PHN, and where that blends in with the state programs, and how that fits in your federal documents and policies as well. A really important thing is these immunisation programs. So people were staying away from immunising for a period of time there and really focusing on just COVID, but at the same time, we need to be aware that we really need to keep our measles injections going, our flu injections, and that really was helpful to have so many people trained in immunisations through COVID. There was obviously the undercurrent of anti-vax, but it still seems that most people are keeping up childhood vaccinations. And again, COVID's really broadened our access to immunisations, but in terms of future outbreaks and future infections, we still need to consider and be really focused on keeping up our immunisation programs. How to plan, we've been through quite a few of these now. Encourage your PHN. So we've got a really supportive PHN locally who are interested in doing some disaster management, which is what this series is about. So there's been a commitment, which is great, and there's an impetus to have a commitment from the PHN, but work with the PHN if there's something that you would like. Use this forum tonight and other forums to really ask your PHN what you need, and be in touch with the links that they do have, and the templates that we talked about, and the matrices. If you have any questions, feed them back. You've got a really supportive PHN staff locally, and likewise the public health units for your local LHDs are often really approachable. I can't say that for everyone, but I certainly found them through COVID. Our local hospital does a weekly mail out of the local infectious diseases that have been picked up in the preceding week. So try and link in with all that data and keep that two-way communication going. I think we're always going to need to maintain this good infection. I know it was very common to go to work and feel like you needed to turn up when you were unwell, but it's really not as acceptable now in workplaces to be unwell, and just having that natural space between you and someone else. So at all times, even if you're not sure there's an infectious disease around, that you're keeping that in your mindset. Communication, that's a great thing to learn with infectious diseases. It can happen slowly in infectious disease, so it can kind of brew amongst a couple of people. You might hear about it on the radio, it might be something you see from overseas, but it doesn't feel like it's at home at the time. Whereas a mass casualty event happens really fast and suddenly on your doorstep. So the communication processes are quite different between the two. So working out in your own workplace, is there a lead that kind of comes forward naturally in your workplace? Is there someone who owns the practice who has more of that lead role? Do you like to have Teams chats? Lots of people set up WhatsApp groups. How do you want to speak to people that really need to hear from you as well? So is that your local media that you're relying on? Are you using a Facebook group? Is it secure? Social media was wonderful. And in terms of what we spoke about at the beginning, really thinking about how you can put some debriefing time into your workplace to work out what worked really well for you through COVID and what didn't work well, because there are great lessons to learn. And again, communicating that back to your colleagues outside of your practices and your workplaces is really useful. So what did we do well? What didn't work? And local data, was there a group of patients or people in the community that didn't have access to a GP, or didn't have access to a pharmacist, or couldn't find good phone connections, or have the intellectual ability to try and set up telehealth or psychology over the phone. Whether people living on the streets, I know we did a lot of work around vaccinating some of our clients who are homeless, but other groups of people that we're missing in our normal traditional communication paths that we can really work on together outside of an acute infectious event. It's really worth kind of planning and thinking collectively. We learnt a lot from COVID. We had these communities of practices that are still going. PHN facilitated, and we had regular updates and talks. A lot of GPs, clinicians, staff all talking together. Really reiterated a lot of the multidisciplinary healthcare and what we were kind of missing for people that we could strengthen as well. I know it was really difficult for physios and OTs, for example, and managing equipment for OTs that needed to be cleaned and getting them into the home and outside of the home, the more hands-on allied health that couldn't be done through video channels. Preparing for physical and mental, I hate the word resilience, so I'm not a fan of it, but it definitely comes up in a lot of the guidelines. There's a lot of things that came out mental health wise and does so with infectious diseases, and being unwell physically, which is all this list on the left, really affects the mental health, and the mental health affects the physical health. So again, with patients in terms of any kind of disaster, but particularly infectious diseases that makes people unwell and sometimes really acutely unwell, do they have comorbidities? Are we maximising how we're looking after people? Are there vaccine side effects that we need to be aware of and monitoring? Loss of life and the effect on family and friends when you've got a mass loss of life event. We're so lucky really that we had spatterings of loss of life, but nothing like those early stages, say, that we were seeing in Italy and out of New York, were just a really huge impact of people passing away and also clinicians passing away. And I don't think we're quite prepared for that still. And thank goodness that didn't happen here for us. The importance of having advanced care directives on as many people as you can. I think that was really difficult with any kind of disease that comes on, but a big wave of an infectious disease. There was a lot of potential ethical frameworks that were discussed locally and in the LHD, who would have access to ICU. And it's really, as much as we can, it's part of primary care, and it's all clinicians really encouraging patients to have an advanced care directive. It's definitely not needing to be done by the doctors, but encouraging patients generally and people generally to have advanced care directives in place. So if they do teeter on the edge with a sudden infectious disease, it's really helpful. And preparing for medications that may be needed. So this is just a little summary of how an outbreak tends to run. As I said, we've all been through this now, so we know a little bit about it. Emergencies, everyone's running around, there's lots going on, there's lots of pathways of communication and information that's coming through. How you're going to deploy and work out in your practice. So hopefully tonight we'll preempt a few people starting some plans about a whole host of things, but tonight we're talking infectious diseases. It's really simple to work out some of the common issues that would come up. Say respiratory, do we have access to puffers? Do we have antibiotics that we would likely need, possibly need? Do we have antiemetics? Do we have fluids that we would need for people in these scenarios? And do we have access to a little bit of a stockpile for some of the smaller outbreaks that might happen in your clinic? For example, the gastro outbreak that was on our doorstep not too far in the past. We talked a little about staffing, whether it's hard because you've got confidentiality that comes into this as well, and it's really important for staff to feel like they're valued in their workplace and also that their health's important. So that's a real balance, but thinking in advance about how you would mobilise staff to help if there is an outbreak and how you can protect staff at the same time. And training is really invaluable. Running through little scenarios as I said, with team meetings. What would we do today if something was on our doorstep? What would we do differently? What can we do today versus what we'd like to do? And standing down time and reflecting, always looking back for lessons that you can learn. I really think it's important to debrief in your workplace after COVID in any kind of scenario. Again, what you did well, what you can improve on, and just making sure that you're part of a surveillance program and picking up any trends that come through. So I hope you found that valuable. There's really so much information out there about this. So I've just tried to pick things that I think are relevant more locally. But happy for any questions or communication now or afterwards.
Thanks, Catherine. It's Phoebe. No questions have come through yet, but I do encourage everyone in attendance to send them through because we will have time to address them at the end.
Lovely. I think I'm passing over to Scott McLennan. And it was Griffiths, was it, Scott?
No, Grafton.
Grafton.
The other GR. Yes, less small.
Tell us everything.
So, that one, there we go. I think my presentation is not on screen.
It is on screen. All good. We can see it.
Excellent, excellent. Thank you, everyone. First, I'd like to acknowledge the traditional owners on the lands on which I'm coming to you from. I'm currently coming to you from Grafton, which is the traditional owners of Gumbaynggirr and Bundjalung. So in the language of Gumbaynggirr, it's Ginaga Yamaga. Tonight, we'll follow a very similar theme to what Catherine was actually going through in that whole PPRR process. But I'd just like to give you a quick understanding of what New South Wales SES and how we are here for the community of New South Wales. So, New South Wales SES is an emergency and rescue service dedicated to assisting the community of New South Wales. We are legislated to actually work here in New South Wales. We have approximately 10,000 volunteers that work with us and staff members right across New South Wales. And we come from all different types of walks of life, bringing with a whole different range of skills, interests and backgrounds. And we started way back in 1955. With that in mind, we work in an interesting framework in that we have our whole thing is we are responsible for floods, storms and tsunamis, and we are what we term as the combat agency for those three particular responses. But in saying that, we have our core capabilities. These are our legislative responsibilities, ensuring that the community is capable and the community is safe. But we have storm and water damage operations, which is when there's a storm and a branch or tree comes through someone's roof, we will actually go and stand on someone's roof, put a tarp over and assist that resident through that particular situation. We have flood rescues, which is where we go on water or in water to rescue people. And I have some stats about what happened last year. We do assist in land rescues, whether that be vertical rescues or land searches. And we do assist other agencies, and we are just about to gear up to assist the New South Wales Rural Fire Service with their response, and we work in a whole different area, a range of areas in that. We also do work in a whole incident management, so we actually take lead when it comes to storms, tsunamis and floods. We do a whole lot of operational communications. I'm part of the community engagement and public information team. So my role is to engage with communities of different flavours right across New South Wales and to ensure that communities understand what their risks are and they're making safer decisions for themselves in timely manners. We do assist in that whole recovery space, and we also do lots of research and hazard planning. So we do assist with road accident rescue, vertical rescue, bush search and rescue. We do assist the New South Wales Police with evidence searches, and we have a whole lot of different types of volunteers right throughout New South Wales that actually work as the community first responders on behalf of New South Wales Ambulance. And such communities of like that is Woolai here on the North Coast, and several other communities where they actually will sit and assist the patient until New South Wales ambulance can actually get there in a timely manner. I think you'd all agree that 2022, last year, for New South Wales was quite devastating when it comes to flooding. And we know that from September or August right through till February this year, March this year, was one of the longest periods of flood. Some of our rivers in the western part of the state were actually in flood for almost 400 days. So last year in 2022, we had over 80,000 requests for assistance, and that's where people would actually, communities would call us and we'd actually go and assist them in some form or manner. We provided 67,000 animal rescues. They're camels in the background. We provided that right across the state, whether it be a wombat, whether it be possums, camels, llamas, alpacas, horses, little horses, tiny horses, dogs, chickens. We'd actually be out there assisting in those rescues. We had over 3,800 flood rescues in New South Wales. It's not necessarily just one person, it's actually multiple people. So, but actually the rescue itself, there are over 3,800 rescues. We did over 2,800 resupplies throughout New South Wales, particularly to those long driveways in western part of New South Wales, where they'd be isolated for anywhere up to 3 months last year. We did 628 medical resupply missions throughout New South Wales as well, ensuring that medicines, and did some very good examples of that. When the Northern Rivers flooded at the beginning of last year, not only did we assist the evacuation of nursing homes, aged care facilities, hospitals, we also evacuated Ballina Hospital in the February-March situation last year. But Corici, the Corici pharmacy actually was completely devastated and impacted by floodwaters. And we assisted in not only getting the nursing home that was completely isolated in Corici, the medicines and the staff that they needed, but also the food they needed. We also assist in road crash rescues, where we assisted New South Wales Police and Ambulance with over 575 road crash rescues last year. We did 30 vertical rescues where we would scale cliffs to rescue patients or people who had actually fallen and slipped. And we did over 2 million sandbags. So our role really is to help community know what their risk is. And depending on where you are tonight, you all have different risks. But it's actually trying to understand what those flood risks are, or those storm risks, or those tsunami risks, and helping you to prepare, to mitigate, or to reduce your stress levels when it is time to enact your plan. Building capacity is what it seems to be. Not only is resilient the buzzword that we're all a bit tired of, but it's building capacity. And capacity is making sure that you have the right information, the right data to make the right decision at the right time, or empowering people to make those decisions. The word that we're tending to move towards, instead of using the word resilience, is being adaptable. And I think in healthcare, so my background is healthcare as well. So in healthcare, being adaptable to the situation that's presenting, or the scenario that is presenting to you, enables your business, your practice, your patient to survive, to thrive. And so we have a whole different range of ways that we do this. And we work with community by implementing programs that increase awareness and acceptance. And these programs, similar tonight, like tonight, or we can come to your individual practice and work with you to ensure that you are flood prepared or storm prepared. One project that we do, so it's understanding who our communities are. In New South Wales, 29% of New South Wales residents actually come from somewhere else in the world. And they usually reside in high risk profiles. You may have those persons living in and around your practices or a part of your practice. but it's actually understanding what those particular cold communities, the communities of alternative languages, what their communities require. One example is here in Woolgoolga in the Northern Rivers, just north of Coffs Harbour. There is a very large Punjabi community. The Punjabi community in and around Woolgoolga generally don't read Punjabi, so providing communications in Punjabi to them is not necessarily the best way that they can understand what you're trying to say, but providing them in English, because they speak Punjabi, they just don't read Punjabi. And it's understanding those different types of communities right round New South Wales. And we're working with New South Wales, with the Red Cross, particularly in Singleton, in Maitland, in Port Stephens. And we're working with other community organisations and local land service, local Aboriginal land councils to ensure that we are appropriate when we are dealing with different types of communities. It's also understanding the way that different communities communicate with each other. So we know the Korean community, for example, they use Kakao Talk. They don't necessarily engage in Facebook, or they do, but they don't necessarily engage in Facebook as fast, but they actually use Kakao. Whereas in China, so mainland China, they tend to use WeChat. And the whole world of China, whether it be Mandarin or Cantonese or Fujian, they actually all use WeChat to actually communicate. We generally, as an agency or as a New South Wales government agency, tend to speak to people in times and actually communicate down rather than communicate with or communicate up. One particular cold or vulnerable community that we do work very closely with is our deaf and hearing impaired community. Generally, when we are speaking with the most people who are deaf living outside of Sydney metropolitan area do reside in the Northern Rivers. So one of the things that you'll always see whenever I'm on television, I usually have someone sitting next to me doing Auslan. We also work with data, so understanding some of the data that comes out. And one of those data is making sure that, and this is important for you in your business, is understanding what you are doing, how many people are doing it, why are they doing it, are you spending the right money? So doing the same thing over and over again has often been, and expecting the same outcome has been aligned with insanity. But doing the same, changing your business practice, changing the way that you communicate, changing the way that you engage, ensures that you are successful. And understanding your communities is paramount. We know, particularly from data that we achieved last year, was that 60% of the community that we work with do not evacuate when we tell them to. That means whether you're a business, whether you're a practice, whether you're an aged care facility, evacuating, making the decision to evacuate or stay is imperative to your safety. When 60% of the community do not evacuate when we tell them to, we often have to go back and rescue anywhere between 20 and 30%. That's a huge impact upon New South Wales volunteers. That's a huge impact upon the community at large. And it's also a huge impact upon the way that we actually work in the future. Helping people to create plans, helping people to understand what their risk is imperative. So how does all of this relate to you? So understanding what your natural risks are. I'll only talk to storms, riverine floods, and tsunamis. So if you are on the coast, so if you're in the Hunter region and you're on the coast, you have a tsunami risk. We generally say that is 10 metres high and 10 kilometres inland. And I'll show you the map shortly about what that looks like. But if you're in Tamworth or in New England, you might get some water views. Riverine floods, it has flooded before and it will flood again. So depending on which river you are on, you'll actually have seen floods before and you may see floods again. There's always the risk of flash flooding, and we've seen significant flash flooding issues over the last couple of years, and there's been increases, and that's usually down to human manipulation of the scenarios of the environment that you're in. And whether it be a culvert, which is where the water goes under the road through a pipe, or whether it be a causeway where you drive through a causeway, they actually impact the way that water flows. And then we have storms, and we do know that the storms are increasing, and the impact that those storms are having are increasing. And we saw that in the last couple of years in Armidale. We've seen it outside of Bathurst, and we saw it in Tormina as well. And not to mention massive Sydney hailstorms. What are your human enacted risks? So what are your human influence risks? And that includes roads. It looks at your buildings, your distance from healthcare facilities or other different types of facilities, and your transportation. So we know that 5 centimetres of water, if you drive through 5 centimetres of water, depending on your vehicle, you could start floating. That's a reality. It's knowing how to, when the time comes, where you're going to go, how you're going to get there, and what could be impacted by that transport, by human enacted risks. What's in your circle of control? So knowledge, information, and your response. But what is not in your circle of control is your environment. And how can you lead your organisation, your family, your community through the challenge that you're about to face? So Catherine went through this in her presentation, and that's the PPRR model. So prevention, mitigation, preparedness, response, and recovery. Prevention and mitigation. So we are working with New South Wales local councils, and we have prevented over 6,500 developments this year alone on floodplains. That's how we're trying to prevent or mitigate the risk on community. We prepare communities and we prepare businesses by having them to have a plan, knowing what they're going to do. And then the response is when we put on our blue lights and we go and save things, and then we transition to recovery. So Catherine went through this when it comes to all things to do with plagues and pestilence, maybe not pestilence, but when it comes to our human responses. But if you look at the different types of risks, so if there's damage or injury, so damage to the building or damage to your staff, you look at the response, and that's to provide first aid, for example. Then you look at your contingency plan. So what plans do you have in place so you don't actually get the damage or the injury to begin with? When you have training, you have someone responsible to ensure that you have risk mitigation. And you also ensure that you've got enough first aid kits, for example. Or if you look at you don't have enough products, you can refer to other alternate products. You can limit the supply of those products in terms of contingency or the distribution of those products you try to sell, and you have someone assigned to being responsible for that. Staffing is always, having enough team members is always a challenge. I know from my days of running a nursing home, it's never enough staff. So you have a significant on-call or casual, and that's the way that you respond to the risk. But you have a variety of staff that are cross-trained. So you have your cleaners and your kitchen staff, or your AINs, and so all your different types of practices. You have cross-trained team members. But when it comes to the storm, you don't actually have an influence over per se, but you do have an influence over the way that could possibly impact your practice. So we know that gutters need to be cleaned. We do know that the more the rain can get into your practice, the more damage it's going to cause, or the water it's going to cause. So know what your checklists are when it comes up to storm season, and storm season is about to start. As particularly when it comes to fire, we all have the very similar: clean your gutters, remove debris, because if the wind picks up a dead branch, it's going to go through your practice, it's going to go through your window. If there's anything that needs to be tied down, tie it down or remove it. We know that about trampolines, if trampolines are left upright, when the winds are picking up, they will fly away. If you turn them upside down and tie them down, it reduces the risk. So that's how you respond, reduce the risk. Have a plan. The big thing when it comes to writing an emergency plan, having a business contingency plan. It's great to have it, but you have to communicate it. Communicate it to each other, communicate it to whoever needs to know, including your staff. Because there may be a day, it always happens when you're not there, something happens. A resident goes wandering, a storm comes through, the snakes start coming up from the riverbed. What's your plan? Make sure that, and Catherine went through this again, I keep jumping Catherine's name in it, but it's the same. It doesn't matter whether it's a storm, it doesn't matter if it's a tsunami, it doesn't matter whether it's a flood, it doesn't matter whether it's a fire. Have a plan. Rehearse the plan. Communicate the plan. And have someone who's responsible at each day, each shift, to actually ensure that it's enacted. I'd like to now share with you some examples of maps that we have. So just to show you what the kind of maps we have. So here's a map. I'm not quite sure where everyone is tonight. So if I look at, let's look at the city of Newcastle. So you can see this is a tsunami warning, and we know that a tsunami will come approximately 10 meters up and 10 kilometers in. The dark blue is actually our flood, 1% flood. But you can see here the city of Newcastle, what would happen if it did. This is our warning reference area, and this is where we would have to actually evacuate people should a major tsunami hit. And when it comes to tsunamis, there are two types of tsunamis. There's a land-based tsunami and a marine-based tsunami. Marine-based tsunamis on the Central Coast and Hunter, New England, or Hunter, New England, maybe not, but if I go down here to Lake Macquarie. So we've got Belmont. I'll scroll in a bit. Hope everyone doesn't spit out their dinner. About Redhead, Belmont. You can see it actually will go all the way into Munya Bay, Dora Creek, Winmarie, Morisset Park, Wairee, North Wharf. Budgewoi, and the entrance, and Gosford. So they're generally the areas that would affect us when it comes to a tsunami. If I look at, take that one off. If I look at a general normal flood, so we know the Hawkesbury Nepean is always a very big flood risk, just waiting for it to load. We don't use the term 1 in 100 anymore. We tend to use the phrase 1% chance of flood, because this is a 1% chance for flood. And we can see the Mooney Mooney Bridge goes under the Mooney Mooney Bridge, but you can see a 1%. The island is actually clear. We do know that in and around Marlow, Spencer, Gunderman, they actually all get affected as well. If I pull out and go a bit further, there's anyone from, I'll show you, I'll go up towards Muswellbrook. We can see what our 1% chance of a flood in Muswellbrook, even though you experienced those late last year. You can see what the historical floods were like and what a 1% flood would look like. We can share this with you when you're building your business plans, or you wish to review what your business plans are like, so you actually can make the right decisions. And we can do that right across the state. Just need to reach out to us and we can help you, depending on where you are. So late last year, on September 30, we also produced what we know as AWS. and we introduced that on the 30th of September last year. AWS now covers tsunamis as well, and later this year it will cover storms. You need to make a decision about what you're going to do. So if we know depending on what your risk is, depending on what your level of warning is, you need to make that decision. One of the challenges that we faced last year, for example, when we had to evacuate one of our nursing homes 3 times, yes, it was built in the wrong spot, but they're making changes about that now, is to evacuate a nursing home takes time. You need to know where you're going. Displacing dementia patients is challenging. Displacing any person into an evacuation centre with high care needs is not, we can't do that. Hospitals don't have the space, and there's not enough ambulances to actually evacuate. So if anyone's from an aged care facility, it is something that we do understand and we work with, and we have been running a range of disaster scenario workshops for aged care facilities. For pharmacies, the way that we could work with the pharmacy in Korakai was, even though their pharmacy was completely obliterated, we worked with their partner pharmacies to ensure that they had a contingency. So it's understanding what the specific needs are of each practice, what your specific needs are, what you need to do to ensure that your business is successful, and have a plan. The best thing at the moment now is what was fires near me is now known as hazards near me. Do download hazards near me on your phone, create an account, set a watch zone for your home and for your practice or your business. You will receive push notifications, and at the moment, if you're in an area like I am, we're getting lots of fire notifications because there's lots of those around, but it will cover fires, tsunamis and floods. You can set for as many watch zones as you want right across the state, and it will communicate that to you. And we're in negotiations now to ensure that AWS, the Australian Warning System, is rolled out right across the state. So much so that Queensland are going to the AWS system on the 1st of November, and Victoria are coming across. Victoria have come across, but they're just refining it, and the ACT will be as well. So for those of you up on the Queensland-New South Wales border, out towards Mungindai and Moree and Tenterfield, you'll start seeing some changes coming across from Queensland from the 1st of November. But please, download hazards near me, and if you have any questions, please do not hesitate to contact me.
Thank you very much, Scott. That was very informative, and it's good to know to have a contact you can reach out to if you have questions about individual hazards assessment, your planning, if you just want some feedback, or if you want to plan a new business and want to know if it's in a danger zone. So that would be one of the best prevention measures. Don't build in a hazard-prone area. That would save you a lot of headache in the future. So having these conversations from a very early beginning on is very important. As I said last time, it's always better to have some plan in place than have no plan in place, and to start the conversation with your team, with your staff, and to regularly update your business continuity and hazards response plan, onboard new staff, and make sure that you do practice runs, practice your emergency plan. It's very important. And we see so many different disasters happen around the world. Some of them are not relevant for our local context, but others are. We are coming into what should be a very strong fire season. So I can only advertise for our next event, which is on the 5th of September. This will be a speaker. We will talk about bushfire, structural fire, and of course, bushfire smoke risk. So talk with your staff, bring them to the table, discuss the individual risks. As healthcare providers, we are inherently affected by disasters, the community turns to us to get some advice, and we are involved in response, in recovery, in every phase of the PPRR cycle. So this is why we created this event. Thank you, everyone. I will hand over to Phoebe now to look at the questions that we received from our audience.
Thank you. I've actually got a few for you, Scott, from Catherine. Catherine, did you want to ask them, or are you happy for me to?
No, I thought it was such a great talk. And one of the practices I work at is Terrigal and the other's Evoca, and I'm alarmingly close to the water. So I was just hoping that you could show us the map around Terrigal Womble, please. So it really is so important. I think it was such a great idea that we can ask the SES to come and be involved in this planning as well. That's really amazing and so useful.
It's also handy to know New South Wales Fire and Rescue, Fire Plus Rescue, they will come and assess any chemicals that you find on your premises. So whether that be any fuels that you don't know what they are or how old they are in your garages, or if you come across paints or tins of stuff that you don't know what they are, New South Wales Fire and Rescue will come and assess that for you, and please do contact them, particularly as we're coming up towards fire season, or actually for some of us we're in fire season. But it's also important to know that, just got to make sure I'm on the right screen. That one, okay. I had to find Terrigal for you. There you go. I'm not quite sure what the address of the practice is, but
I think we're in the red. Interesting.
So the
and do you take heed by the tsunami alert system? Could you comment on how good that is and whether people would have time on the coastlines?
So the majority are, so there are the two types of tsunamis. One is the land-based tsunami. We do not have a very strong high risk of land-based tsunami, because that's where you get a landslide that goes into the water and pushes the water. Sorry, I'll get the camera shot. It pushes the water. Whereas a marine-based tsunami is one that happens off the coast. So we saw that beginning of last year. That's how we started 2022. It's a tsunami alert. That was the water eruption from Fiji, Tonga, and that started pushing some water in the wave towards us. That's the majority of our risk. Now, the risk is generally, we say, the majority of the risk is 10 metres high, 10 kilometres in. Now, depending on where the incident has occurred in the Pacific Ocean, will depend on how high that wave is. Now, Aboriginal stories have stated throughout history that the ocean comes and takes people away. Now, that's why the majority of the Wiradjuri people actually say there's not many coastal Aboriginal nations or coastal Aboriginal people, is because the ocean would come and take people away. So the reality is it has happened in the past and it will happen again. We have geological evidence to show us that tsunamis have happened right up and down the coast. And here in Grafton, I don't know if anyone has been to Grafton, but there's the old bridge in Grafton. There's a nursing home right at the top of the old bridge. There's geological evidence underneath that to show that there was water over that at some point in the past. So we have, one of the challenges that we face as a community is whenever we build walls, whenever we build levees, they build false senses of security. And Mother Nature, love her dearly, but she'll find a way. So the alert system that we use is the same as what the police use. So the 4444 number, and they use that to alert for missing persons. We will use that in an emergency, and we will alarm people anywhere up to 6 hours or more for a tsunami. We will use that to evacuate people right up and down the coast. And we've got that section, and it's based on how many telephone calls and how many text messages can be sent out. I know in September last year, in the Northern Rivers, there was significant rainfall coming from, there's an eastern low coming down from Queensland. We sent out 397,000 text messages and 67,000 phone calls for people who are registered for phone calls. Not with us, but with who need telephone calls rather than because they're hearing impaired or aged. That took us 4 hours to get that across. The federal government has done significant funding for people in Australia, and they've invested in what is known as the STAND program, which is strengthening telecommunications against natural disasters. And that's increasing the bandwidth and evacuation centre access and our access to telecommunications and satellites to ensure communities are communicated with. So did you want me to go a bit closer in?
If you can head up towards Wamburrow, I would love it. It will save me looking it up in half an hour. The other comment I had in your amazing talk, I think we've reiterated about communication so much and all the different meanings of that. So between essential workers, between the SES, but it's really interesting to hear you talk about the communities. And I think I alluded at trying to think about the communities that we may miss in our normal forms of communication. So I think I'll be taking that back to my practice, really thinking a bit broader about the people that we might miss. And also just communication with staff and recognising that all different staff don't need to be leaders and they don't need to have the same strengths. So really finding the beauty in all the different styles of staff that you have and patients that you have, and using people appropriately for what they're best at. And there's no problem if they're not good. Yeah. If they're not good in a disaster and frontline, that's fine. They'll be good at something else that's really beneficial as well.
And a lot of them actually have their own challenges going on at home. So it's trying to recognise that just because the practice, the business is going through a disaster, that also means the individuals may be going through challenges at home, and particularly for people, parents with children or fur babies, they've got their own proclivities that they need to know. We also have the issue is one of the challenges that we face is that we wear a blue shirt very similar to New South Wales Police. So I tend not to wear this a lot, only when I'm doing formal things like this. A lot of the cold communities come from war-torn nations and have issues. So when we sent the Army or Navy or Air Force in last year because we needed to, that's not necessarily going to happen in the future as much. But communities were very adamant that they didn't want them. I have to be careful when I go into some communities wearing this because people think I'm police. I'm not there to arrest people. Although I did wave my finger at someone this morning who was using her phone while she was talking, and she dropped the phone then because she was driving. She was on the phone. It's like, and she went, oh. Then I can drive. Yes. And so I use my powers. I use my powers for good, not evil.
It's good to hear. Catherine, we did have one question come through for you. Would you recommend preparing for different pathogens? For example, pathogens with different transmission routes, or would you keep the business continuity planning to a more universal level?
Well, look, how much time do you have really? That's the main question, and how much interest you have. I would probably be looking broader at respiratory, gastro, bloodborne.
Okay.
And if you have time, like we're still probably most likely to have a respiratory pathogen. So I would focus time on that. And if you wanted to break that down into a few different, perhaps that's useful, but I think broadly in general.
Sure, thank you. Well, we don't have any more questions.
I have one more. Can I have one quick one?
Please.
This is great. I know it's difficult, and we felt as clinicians through COVID, people very resistive in the end, and quite an upsurge of people not wanting to take what we perceive to be quite logical advice. And I'd imagine you have quite a lot of experience of that with people wanting to stay in their homes against advice. How do you
burning down their 5G communication tower.
Yeah.
It's really difficult. So here on the East Coast, our floods come very quickly. And you're dealing with people in high emotive states, and you're cutting. Facebook is not the truth, is not book of the world. and cutting through the negativity or the conspiracy theories is hard, it's challenging, and it takes a lot of energy. I have teams of people that, so when we go operational under Public Information Officer, so my role is, I'm usually the media whore. But I have a team of people that have to sit there and troll through social media, because that's where we either we get truths, confirmations, or we have to dispel myths. Sometimes it's best to ignore it, and hopefully you have enough, which is when we're not at war, so when we're not operational, we spend a lot of time building our confidence, building our resilience, building our adaptability, building the trust that the community have in us to ensure that the communications that we are communicating when we have to is listened to. But knowing that research that came out from last year that 60% of the community will not evacuate is hard. I know on December 29 last year, I had to make the decision to evacuate Menindee Lakes. Menindee had been in flood for 6 months, and New South Wales Water made the decision to increase the release. And that was going to put water through 40 people's homes. They had 2 days notice. There was nothing we could do. We couldn't do, they had 2 days notice. I had a woman saying, what am I going to do with my grandmother? Or what are you going to do with your grandmother, or with my grandmother? I can send people around to her house to help lift furniture or to move whatever we need to move, but she's in the path of the floodwater. Well, what are you going to do about it? She can go and stay with you. No, she can't. Okay, so I'm giving you all the information that you need to make a decision with to keep her safe, and we'll send people around, we'll lift it for you, but I can't do everything for you. You're going to have to make a decision for you and for your grandmother. You have to have those heart-to-heart conversations. It's the same for in healthcare. You have to, at some times, have those heart-to-heart conversations, those courageous conversations, I don't know about that term, or those difficult conversations, but you have to do it with a sense of empathy. You have to do it with a sense of compassion and with no agenda. Provide a range of solutions and help people to make the right decision for themselves. That's, yeah, you would face the same issue when it came to COVID and all the conspiracy theories.
Okay. Catherine, any more questions? No, thank you so much. That was very, very interesting. Once again, thank you to our wonderful presenters. Thank you to Ellen for being the driving force and dragging us all together. And thank you to everyone attending tonight for spending your evenings with us. We really do appreciate it. Ellen, any closing remarks?
It was lovely to meet everyone again tonight, or maybe for people who joined us for the first time. I'm looking forward to host the third event on the 5th of September. So registrations will open in the next day or two, and we will send an invitation out to everyone who joined this or the last event. And yeah, stay safe and be prepared. Have a good night, everyone. Thank you.